audio issues. They had an echo online, but now we have an echo in the room. So we are going to go back on mute and see if we can figure this out. 1 second, please. All right. All right, we're going to go ahead and call to order. All right, so thank you for everyone's patience. We will call to order at 12:03. Shelley, if we can do a roll call for those of you in the room, I apologize. We have my iPad, which is now our speaker. So
Amber Rice. Present. Dan Spade.
Dan Spade's here.
Franco Castro Marin.
Here online.
Frank Walter.
Here.
Gail Bradley.
present.
Eve Godstater.
Present.
Jason Johnson. Here. Josh Gaither. Julie Augenstein.
Present.
Kevin Foster.
Present.
Great, we have quorums.
Excellent. Well, thank you, everyone. I think this is the first time in a while that we've had the entire committee with us. So thank you for joining. Just a reminder, the attendance packet is in your agenda. There are a couple vacancies that we have. The two vacancies are a physician who specializes in severe acute head injury treatment or spinal cord care and has an interest in EMS, as well as an EMS physician from Western region. Just a reminder, I know we do have at least one applicant pending for one of those roles. Those are up to the governor's boards and commissions. So thank you for your patience. We just get those appointments when they are passed. So thank you for everyone who has submitted those. Just a reminder for some housekeeping issues, everything said as part of this meeting is part of the permanent recording that is shared to the Bureau's website. So this includes both the audio as well as anything that is in the chat. Also, one more reminder, if you have missed 2 or more meetings, we will contact you to see if you're still interested in serving on the commission. For any members who are expiring in 2024 or who have expired, please make sure that you put in for your renewal on the governor's boards and commissions website. The link to that is in the agenda packet as well. A quick update on naloxone leave behind. We are really excited. I got an inquiry yesterday. We are up to 21 agencies who are now enrolled with our naloxone leave behind program. So we are quite excited to see some increase in that program as well. I would like to welcome Dave Hansen, who is new to the Bureau and has taken over for our FR Care grant as part of the naloxone leave behind program. He comes to the Bureau with quite a bit of law enforcement experience, as well as managing another FR Care grant. So we feel very fortunate to have him as part of the team here today. In your agenda packets, we do have the 2024 meeting schedule. So that was shared by Shelley. And if you have any questions, hopefully we do not have any major conflicts. We always do attempt to screen that before that is published. So next for Bureau reports, I will turn it over to Chief Garcia.
Thank you very much. And I don't know if they can see our faces on here, but no,
I have it turned off.
Okay. Well, we have a quick Bureau report we'll run through. If you were joining us earlier this morning for STAB or EMS Council, this will be a complete repeat. We will share this slide deck out as part of the package for today's meeting. We have updates on our current EMS and trauma system numbers, although I'm told since we created this slide, we have hit 22,000 certified emergency medical care technicians here in the state of Arizona. Our big goal this year is to make sure we get better stats and a breakdown of our number of emergency medical care technicians that are actively working per county and per state. And so we will be doing a deep dive with all of our agencies to make sure that we have updated rosters and updated numbers in terms of our actively working workforce in the pre-hospital setting. Our next slide shares some information on our annual appropriation that we've received. We have been able to slide $850,000 off the top to give to our 4 local EMS coordinating systems. Those are the 4 regional councils that we work with closely. And of note, I just want to say we are so appreciative of the rural paramedic training programs and scholarships that each region has provided to EMTs bridging to paramedics in those 4 regions. We're just thrilled to hear the success of that program, and we hope to be able to continue to fund that program moving forward. We are working with the 4 regions on the EMS and trauma needs assessment and strategic plan, and that goes right into that next slide. These are our top priorities for the Bureau in 2024. And we will be coming back to the committees and asking you to review, of course, our EMS needs assessment and strategic plan. We look forward to that. Some other priorities listed there, we will be doing several rulemakings this year focused on EMS workforce development and training. And we're working on quite a few other programs, but in the interest of time, I will not go into great detail. In our next couple slides, I just want to let you know in the next one more, there we go. In September, we will be coming back, especially to EMS Council and STAB, and keeping MDC informed as well of our draft strategic plan as well as the needs assessment report. So please stay tuned. We really appreciate all the feedback we've gotten so far in this process. And I will go into some legislative and rulemaking updates. We have here listed the bills that were passed in 2022 and 2023, and we share those because there were quite a few bills that did not go into effect until January 1st of this year. So those are available for review. House Bill 2609 has gotten the most attention, and some of you may have participated in our House Bill 2609 sessions that we hosted in December. On the heels of House Bill 2609 going into effect, there was also some recent legislation during the 2023 session that has become effective. And now heading into 2024, legislative session has kicked off. These are two bills that are on our radar. You see them, House Bill 2290 for certificates of operation and interfacility transfers, and House Bill 2066 for behavioral health transportation and providers. The Bureau has not had an opportunity to deep dive into these and review them, so I couldn't share any great detail with respect to these bills today, but we will be taking a look and discussing them. And at this point, we do not have an official position, and I just want to say we are not sponsoring any legislation this session. So we are reviewing at this point. Of note here, as we go to the next slide, several of those bills that you saw do require that the department does rulemakings to establish the rules for this new legislation. Under those last three bullet points you see there, this year we have teed up the ground ambulance rulemaking package. We also have EMCT certification and training rules that will need to be updated based on new legislation. And we will be relying heavily on Medical Direction Commission to help us update EMCT scope of practice. That will include scope of practice for EMRs. That will also include scope of practice for critical care paramedics. And so we definitely thank the commission because we rely on you heavily to make those recommendations to the department to be able to update, especially scope of practice. Let's go ahead and fly through this to slide 20, Shelley, if you don't mind. You will get all of this in your packet, but I just want to, for a minute, stop on next steps in the rulemaking process. We do intend to convene work groups and special meeting sessions on the following topics. We talked about state standards for critical care paramedics and EMRs. We will also be convening a rules work group that we've worked with now for several years to discuss interfacility transport reporting requirements. So those are some things we'll be focusing on this year. And we want to make sure that the committees know we will keep you updated on upcoming rule meetings. I think from here, Dr. Bradley, I will pass it off to Julia, and then we'll do TJ and Batzel.
That sounds good. Thank you. Julia, I will move this closer to you just so we can make sure everyone can hear.
Thank you. All right, just a quick update on the SHARE program. So we have been working over the last 6 months or so to transition the AED and CEDAR registries over to ADHS from the University of Arizona. We have successfully migrated the AED registry and have a new website live at aed.azdhs.gov. And we are working on doing the same for the CEDAR registry. We hope to have that live around the beginning of February, and we'll send out communications for that once that has been completed. If you have any questions about the process, feel free to reach out to myself or Adam Rodriguez. And I think that's all.
And I just want to say a big thank you to the entire SHARE team here on the ADHS side. This has been a huge transition to bring that database over and to really work on bringing that back within the ADHS umbrella. So a big thank you to everyone within the Bureau team that has put all the effort and time into that transition back. Next, Voxel. I think we'll do just a brief we'll just kind of briefly highlight where the dashboards are. I realize we did not provide a hyperlink in this agenda, but we can make sure we share those out as well, just because we want to have make sure we have time to get to the rest of the agenda. Voxel, if you can just quickly do a quick overview of both, and then we'll make sure we share those links to the committee.
Sure. Yeah, let's go. We have few dashboards available now, for using trauma registry and EMS registries. There is one is a 911 call, which you guys are aware of, which is almost a real-time data, talking about, what is the call volume. Then another one is a EMS incidents, which gives you an overview of EMS registry for like the entire EMS registry, kind of all. What are the primary impressions? What are the demographics, response times, and things like that? And then the trauma registry, the trauma injuries by year is an overall overview of the trauma registry in that. And then we have few years of data available in both of these dashboards for the comparisons. There are many new filters have been added to look at it, the picture in a different way. Like, for example, we want to look at the pediatric population, geriatric populations, or for the EMS side, if you want to look at the regional, in northern central region, if they want to see their own reports, those kind of filters are now available in the dashboards. We have then few disease specific, not disease, this is like MVT related trauma and falls incident, and MVT related trauma has been updated. Falls is the one which still needs an update. I mean, new data needs to be added to that, but these are some of the examples of all the dashboards available. Yeah. If you guys have any questions, anything, I can take that.
Sorry, Voxel, I realize I'm having to unmute my phone and not talk loudly to the room audio. So a big thank you, Voxel. That was a great summary and very brief overview. For those of you who are at STAB or EMS Council, Voxel provided the overview of the trauma dashboards as well as the EMS dashboards that are on our website. These are replacing what used to be the 25 to 30 page PDF document that the committees would get, and I think is much more user-friendly. A good example that we had in September, STAB had some questions and updates that they had wanted to the STAB report, and Voxel was actually able to go and update our dashboards based on that. In the old format, we would have gone through the whole year cycle before we updated a static document that could not be changed. So a big thank you to Voxel and the entire DQA team for all of their work on that. Any questions for Voxel? All right, next, TJ, are you on the line for a National Registry update?
I am.
Excellent, thank you.
Good morning. One of the items that's going on currently is a project with National Registry. They're updating their mission, vision, and purpose statements. They've already reached out for some feedback to state officials. They're going to be doing the same with programs and training managers. As part of that, they are relying heavily on evidence-based guidelines for a lot of the items they do, especially with test writing and the new National Continued Competency Program. So they've got some updates that they've released with that. Up until the 2025 research cycle, they're using the 2016 model, and the list of all the required subjects and topics are listed in that hyperlink. And in the 2025 model, that's going to apply to folks that expire after March 31st of 26. They're going heavily with the evidence-based guidelines. They've included a number of links and document to the peer journals that they're using to justify those moves, and are planning on keeping them updated with current information in that recycle period. So those links list all that. They've got links to their current resolutions and initiatives there as well. They're also starting, they just got some funding for a occupational risk study that's going to be one of the most comprehensive looks at the risks that firefighters and EMS workers are facing currently, and also have a workforce study, which is one of the few that has a captive audience that we have national data on, because they picked the 9 states or political subdivisions that require national registry to recertify their national and local certifications. So it kind of shows the movement of nationally registered individuals in and out of the workforce and what assignments and roles they're actually working in. So unless anyone has any questions, that's all I've got.
Thank you, TJ. Thank you, TJ. Thank you, TJ. Thanks, TJ.
All right, we did it.
Now I'm through. Now I'm through. Now I'm through. Now I'm through.
All right, sorry about that. We were trying to get the room reconnected. And we're unsuccessful with that. So thank you for bearing with us using my iPad. So hopefully everyone can hear the audio okay through that. We keep moving on the agenda, and I'm actually going to use the chair's prerogative and move it around a little bit because Dr. Walter, who is joining us today, did have another meeting that overlaps us. I wanted to participate in the conversation on our discussion and action items. So I'm going to move down the agenda. If I can get a motion to discuss, amend, and approve adding nalmefene to table 1. So
Yeah, I'll make a motion.
Second. Okay, thank you.
Second.
I've got Amber and Julie.
Yes. All right. So I will open this up to discussion. I know Dr. Walter, I want to make sure you have your time to speak on this, and then anyone else who would like to speak as well. We cannot hear you yet, Dr. Walter, if you are speaking. Sorry.
No, I haven't spoken.
Okay.
So, do you want me to address a specific question or just share my thoughts about the pros and cons of naloxone versus nalmefene? What's your pleasure, Dr.?
If you would like to go ahead and just share from a toxicology perspective, kind of your expertise and pros and cons of the two, that would be great.
Sure. So my thoughts are that for both in the field with EMS and we receiving patients from EMS in the emergency department, naloxone, as we all know, has a shorter half-life and therefore shorter duration of action. Half-life of naloxone IV is about 1.2 hours. IM about 1.4. In intranasal 1.87. I'm sorry, 1.8 to 2.7. Whereas nalmefene IV, and I know we're considering the intranasal, but the IV half-life of nalmefene is 10.8 hours. So the titratability of naloxone is much greater both in the field by EMS professionals and for us in the emergency department. Duration of action is different than half-life. Duration of action will depend on what opioid the patient has used, and that patient may or may not know what opioid they have by whatever route they've given it to themselves. And so the duration of action will depend on how much of that opioid is present that the patient used. Their tolerance, their up or down regulation of their mu and other opioid receptors, but predominantly mu, and the amount of either naloxone or nalmefene given. So let me just give you an example from my last shift. We had a patient who got naloxone, was apneic in the field, somewhat woke up, but had continued yawning, piloerection, agitation, requiring and combativeness, aspiration pneumonia, or aspiration of gastric contents, and he had received naloxone. So the effect of that will be gone much more quickly than nalmefene. We had to use high dose after the endotracheal intubation and paralysis. We had to use high dose fentanyl, propofol, and we had to add Versed for this patient. And he continued to have piloerection in spite of all that, and despite of high doses of fentanyl, propofol, and ultimately we had to add Versed to allow pan scanning since he was found beside the road. But again, if we use nalmefene, we'll lose that titratability. We'll have to have longer high dose opioid use managing withdrawal in the emergency department. Also in the EMS in the field, they can give incremental or smaller doses of naloxone to hopefully titrate to effect rather than have a long-acting opioid antagonist on board such as nalmefene. But those are just my general thoughts. Does that address your question, Dr. Bradley?
Yes, thank you. I think that's a good kickoff on the conversation. Thank you.
Thank you.
Gail, this is Dan Spate.
Yes, Dan.
To me, this is a perfect example of a setting where the potential, all of the potential arguments are at this point are dotted line from what we know from elsewhere. There's never been, and I'd be amazed if there ever is a comparative, a randomized study between the two drugs we're talking about. And to me, the important, Frank just, I thought, beautifully exemplified the issue of adding a long half-life, even longer acting potentially blocker that is functionally you can't titrate at all. The concept of using a drug with that long of a half-life as titration is, nobody even thinks of it that way. And the other thing that's important is we're intervening on a complication of medications that the patient, medications or illicit drugs that the patient has taken. And as we intervene, we know even with the short-acting naloxone, sometimes we precipitate really, really consequential iatrogenic complications. It's still better almost always than the person remaining apneic, but we do that and sometimes have to deal with that for hours, even with naloxone. So the idea of precipitating iatrogenic complications that may last for probably 15 to 20 hours, just to me makes no sense at all. So I think we can discuss it further if we want to, but I think the issue of adding the really consequential risk of induced withdrawal for a really long time is probably the single most important piece of information from my perspective.
Thank you, Dan. Comments or discussion from anyone else in the room or online?
Hi, my name is Justin Galan. I work for Indivior. We are the company responsible for bringing Opfi in the nasal spray, nalmefene in the nasal spray form to the market. And I appreciate the comments that were made. I will not claim to have the medical background that both of you have, but I think that there was an important piece touched on when it comes to clinical data. And there is, in fact, some data out there that compares nasal naloxone 4 milligram to nasal nalmefene in a 2.7 milligram form. It's a head-to-head study. It is randomized, and we would be more than happy to provide all of you with that information. And I would also go as far to say is from an EMS perspective, we absolutely hear you. I've worked in this space for a long time. I helped launch nasal naloxone. We're very aware that in your capacity with your level of professionalism and knowledge and medical background, that titrating with the IM is the way to go. And you are the ones that have the understanding and the ability to do that. Our intention was with Narcan and now with OPVEE is really to provide something for the community, for first responders, perhaps before you are all on the scene. And it's the ease of use because of the nasal formulation. And it's also to address the current drug supply. So OPVEE is the only one indicated for natural and synthetic opioids. And I think that that's an important distinction compared to the tools that we have available now. Our primary treatment goal, as I know, I'm assuming yours is to save a life. That's priority number one to us. If we can do it in a safe and in humane way, of course, that's the goal as well. But primary treatment goal is purely to save a life. I'm happy to answer questions. We also have a PharmD on the call from our company as well, and she is equipped to answer some of the more difficult questions. So please feel free to ask. And thank you for the time, Dr. Bradley.
Thank you.
A question in the chat.
I see a question from Matt regarding the cost.
So the cost is, well, essentially, if the state of Arizona was willing to bring it in and make it available as they do Narcan nasal spray, the cost would be free. The cost to the state paying using the federal grant, the SOAR grant, or in fact, if you were to use settlement dollars, OPVEE is an allowable cost. It's $75 per unit, and there's 2 units in the box. The Aptar device, the nasal spray device, looks exactly the same as Narcan with a green label that says OPVEE. So, so $75.
And just to clarify, that's you said there's 2 units in the box, so the box would be 150. Is that correct?
Sorry, I apologize. 2 doses. There's 2 doses.
2 doses. Okay, so
one
thank
unit
you
is
for
2 doses.
clarifying. Okay, so
Yes, so
75 for the 2 doses. Okay, thank you for clarifying.
Exactly the same is the way Narcan nasal spray is packaged.
Okay, thank you. Amber?
I think my comments would be, my thoughts first about the precipitated withdrawal issue, and we do have a fairly high number of folks who refuse care in the emergency department.
Amber, can you get closer to the mic?
Yeah, you can move for a second.
I will walk around the room, yes.
Sorry, Gail.
That's okay. I've been sitting all day. It's good exercise.
Sorry, Dan. My comments, my first comment is about the precipitated withdrawal issue and the potential length of time that we would have someone in precipitated withdrawal and the risks of this being pretty significant. We have a fairly high number of people who do get naloxone after overdose and do refuse care in the emergency department. So this presents a fairly high risk population. The other concern would be the resource utilization in the hospital. So I think that Dr. Walter gave a pretty good example of a case with very high resource utilization in an emergency department setting, specifically due to the effects of precipitated withdrawal in a patient and the fact that they got a medication that now makes it difficult for us to manage them in the emergency department. This is a big level 1 trauma center that we're talking about here. And I can only imagine what happened if one of these patients came to a much more resource limited area or resource limited hospital where you might only have one provider on. And now this provider is managing a patient in precipitated withdrawal who can't manage their airway for half of a day. And so I think this presents a pretty significant risk, not only in the pre-hospital setting, but now we're dragging this for a prolonged period of time in the hospital setting. I can't find any clinical trial data that addresses the safety of this medication when used on actual patients in the pre-hospital setting. So I think that that's still a big question in my mind in terms of just the safety and the risk. And I think given those things, I can't find that there's a significant benefit that would, in my mind, outweigh any of these risks for giving this in the pre-hospital setting, especially given the potential for resource utilization and increased costs and risk to patients. So those are some of my comments, but I'll stop there.
Thank you.
Yeah.
Want me to talk while you're here?
Sure, yeah.
Let's go around the table. I'll echo Amber's comments. I think I'd add on two additional thoughts. The first one is many of these individual patients have co-ingestions. We know that opiate use with methamphetamines, with other stimulants is very common. And when we give larger doses, those patients are more likely to wake up agitated. In our current political and legal environment, management of an agitated patient in the pre-hospital setting is incredibly risky. I'm very, very hesitant to move forward with something that would increase the number of times we have to chemically sedate people in the pre-hospital setting. That's just not something that at least I have the legal risk tolerance for at the moment. The second thing is I'll bring up, totally missed my radar when I was chatting with one of our addiction medicine specialists about this medication. She brought it up, Dr. Gwen, for those of you that know her. She mentioned that the psychological impact that patients experience with this can actually have some negative ramifications. And full disclosure, I'm not an addiction medicine specialist. I'm just repeating what she told me. So if I screw it up, no, you can blame me, not her. When we give a longer acting opiate antagonist, those patients experience obviously longer withdrawal. The longer they're in withdrawal, the less likely they are to be willing to go into medication-assisted therapy. Initially in my head, there was some appeal in that if patients are experiencing withdrawal, they're more likely to go on Suboxone. She actually said that's not true. That's not what they see in clinical practice. So I don't see the benefit of that end of the scale. Again, not my area, but worth mentioning.
Thank you.
And this is Jason, and I just want to echo what they're saying. And as I guess representing the rural aspect, we go down to single coverage between 1 a.m. and 6 a.m. And if a patient comes in like this that I'm having to manage by myself all night, that's going to be shutting down the ER for anybody else who comes in, especially if I have to now intubate that patient to get him to the CT scan or for whatever reason. So definitely from a rural standpoint, this would really create a bigger hindrance than it's worth.
Thank you. All right, any further comments from anyone online?
Dr. Bradley,
Yes, go ahead.
just a quick response just to everything that was said, and I certainly appreciate the feedback and the thoughts. I think that there's a huge gap, and you know, you guys are going to make a pretty big decision here, and I think there's a gap in data, right? Several of you mentioned it, where it's not so good for nalmefene because there isn't data, but then again, there really isn't a whole lot of data that says that it's going to cause precipitated withdrawal, and I think we can't use single incidents. Just like we won't use the anecdotal data that we have of it being used in the field. It's just not fair, right? And I think that because there is a lack of data that makes this decision very difficult. So I just want to take everybody back 7 years when Narcan nasal spray came to market. 4 milligrams was scoffed at. It was, everybody pushed back, including the EMS community. It was too much. It was going to cause precipitated withdrawal. And to this day, 7 years advance, yes, it does, but usually when it's administered incorrectly. When it's administered correctly, it doesn't typically cause precipitated withdrawal, although it's predisposed to because it is a class effect. So I think we're taking a pretty big leap, making a pretty big decision without enough data. And I would say that's the only analogy that I could make, is that we went through this same thought process 7 years ago when the 4 milligram first came to market.
I'm going to go to Dr. Zeidler next, and then Dr. Walter after that. Josh?
Hi, I just want to mention.
Oh, Josh, sorry. Can you speak up? You were very quiet on our end.
Yeah, is this any better?
Tiny bit.
Sorry, I'll yell. I assume that nalmefene comes in both an intranasal and an IV form. I would just point out that if we add it to the list like it is now, that would include, I believe, that problem, which would be in basic EMT, it would not specify only the nasal like we do so for naloxone. So if it does pass, we may need to figure out a better way to put it in the table, similar to naloxone.
Thank you, Josh. Next, Frank.
I wanted to thank Justin for his comments. And as he said, precipitated withdrawal is a pharmacodynamic effect that is a class effect for any opioid antagonist. And so it really, and I just use a specific example to illustrate that the longer that withdrawal occurs, the more difficult management will remain. Also, both of the drugs, both naloxone via any route and nalmefene via any route, can cause withdrawal. It's the duration of the withdrawal that is, I think, the concern with nalmefene versus naloxone. In addition, if we want to intervene in the emergency department and are able to discharge a patient that doesn't, different than the example that I had, somebody that wakes up, we observe 4 to 6 hours, we have that caring discussion with them about, hey, this is an opportunity to change your life. The paramedics saved your life. You weren't breathing or probably would have died. Starting somebody on Suboxone, which has both partial agonist and antagonistic effects at the various mu receptors, partial agonist at mu and antagonist at kappa and delta, may be more difficult and maybe less likely to be effective, while there's still some antagonistic effect from nalmefene on board. So those are my only thoughts, and I thank everybody for their comments, and thanks for bringing this forward. Obviously, as a toxicologist, we're always interested in potential opportunities and as emergency physicians, for any of our patients. So thank you very much.
Thank you.
Dan, I think we had a motion to put the discussion on the table, but do you need a motion in one way or the other to get it on for action?
That was the motion, was to discuss, amend, and approve adding it. So if there's no further discussion, we can take a vote.
Okay, so just to clarify, the motion on the table that's been discussed was to add it. So a yes vote would be to add it to the drug box, and a no vote would be not to add it.
Correct.
Is it okay as it appears?
Yes. So I don't hear any further discussion. I will say we'll start with the nays. Anyone opposed? We'll do just a roll call vote for this one. Anyone opposed to adding nalmefene to table 1? We'll start with those in the room. So opposed, please raise your hand. So we have a no from Jason, Josh, Amber, and Eve. And then we'll, Franco, is that a question that you had?
No, that's a no vote.
Okay, thank you. We'll do a roll call online for the vote. So I got you first. So I thank you, Franco. That was a no. I will try to go in order here, make sure I capture everyone. Dan?
Vote no.
Julie?
I vote no.
Kevin?
No.
Frank?
I'm opposed to adding nalmefene at this time.
Thank you. Did I capture everyone's vote? I believe I did. Okay. All right, so the motion does not pass. Thank you everyone for the discussion. And I appreciate the ability to move the agenda around just so that Dr. Walter had the opportunity to participate with that. So thank you very much.
Thank you.
All right. So we will go back up the agenda to our standing committee reports. We will start with Dr. Johnson for Education Committee report. Oh, yeah, I'll walk over. Yeah.
All right, for the Education Committee, we discussed the EMR first responder curriculum as well as the critical care paramedic endorsement. Both of these were non-voting items and they're going to be discussed in rulemaking. Pediatric seizure training and pediatric airway training was approved and are now posted. There's also creating a second work group to discuss and create training for fall prevention and another one for sepsis. Then Matt's also going to be reviewing some offline CPR and Amber's reviewing the offline safe sleep.
Thank you. Thank you. And Julie, you are correct. I did skip the agenda. We had a formatting glitch I just saw, so it was not.
You ready for me?
Yes, so I will go to you for the TEPU update. Thank you.
Perfect. Minutes were approved as presented. Rachel shared slides to discuss HB 2609 response time reporting, and Anne shared resources available that are posted to the web pages for AZ Peers and NEMSIS version 3.5 topics. Dr. Bradley gave a share update as well as she presented dashboard data for MBT. There was some discussion about drug and alcohol use and the need to adjust to add fentanyl results. There's also discussion about hip fracture data being captured versus not captured due to hospitals being designated or not. And that ends my summary for the November 16th meeting.
Thank you. And just a little quick side note on the hip fracture. We had a really robust discussion this morning at STAB regarding actually forming a work group out of STAB to look at falls and hip injuries. So really one of, I think, the best STAB conversations that we've had. So when that work group is live, that will be open to the public. But I did want to make sure that we open that to members of this commission as well, because I think there was a really good discussion, excuse me, looking at kind of where these patients may potentially go to get the best outcomes and care. All right. Josh for PMD report.
All right, PMD, the highlights. We approved our minutes. It was a surprise. Bylaws were reviewed and approved. We did discuss the EMR and critical care paramedic curriculum, like we're going to do here again in just a few minutes. We also reviewed the T3Gs for behavioral health alternative destination, and we discussed adding IV antibiotics to table 1. That did not pass. That's the updates for PMD.
Thank you. Aubriana.
Thank you, Dr. Bradley. So our last PACES meeting was on November 16th. In this meeting, we approved our minutes as presented and improved our bylaws as amended. PACES is welcoming individuals for our vacant position of pre-hospital coordinator. So if you are interested in this position, please forward myself your CV or to Adam Rodriguez. PACES and the Arizona EMSC are offering the didactic portion of the NRP training. And once I get back to my seat, I will provide that link in the chat. And then lastly, the Education Committee has approved the pediatric seizure training and pediatric airway management training, which is now available on our State Department website. And we welcome you to attend our upcoming PACES meeting on March 21st at 1:30 p.m. Thank you.
Thank you. I think there might be someone who is off mute. If you can maybe just check your devices, that would be wonderful. Thank you. All right, next, if I can get a motion to discuss and amend and approve the meeting minutes from our September 21st meeting. Shelley will display those. We'll scroll through that.
This is Julie. I can make a motion to approve.
All right, thank you. We got a second here in the room. Any recommended amendments to the minutes? Hearing none. Anyone opposed, please say nay. Any abstentions? All those in favor say aye.
Aye. Aye.
Thank you. All right, next discussion about the upcoming EMR and critical care paramedic rulemaking update. So to give a little bit of update on the process, so there has been some clarification in regards to what we are able to do in regards to EMRs. So we had discussed at PMD and education, looking at EMR, and upon further review of the actual statute, the Bureau does not have the ability to certify EMRs, which is a little bit of a wrinkle in what we are able to do. The Reader's Digest version and how it applies to the Medical Direction Commission is that we will need to create still a scope of practice. Right now, there is the rule writing ability to address training centers, so that is allowed. So training centers, we can actually regulate and update that for EMR training, but we're not actually able to certify them. So little distinction, but the key thing is we are going to need to create both an EMR scope of practice and then a critical care endorsement to the paramedic scope of practice. So I'm really excited about the critical care. This is one of those things when I first came to the Bureau in 2019, I kept asking is how do we get this in Arizona? And we are finally able to move towards that. The time frame for this is going to be, it's going to seem long, but it's actually pretty quick. So the ask for this committee is that we are going to need to form a kind of a subcommittee to really look at updating these. So we want to have, as we did with previous scope of practice models, that went to PMD first and then comes to MDC. As we know with the structure and timeframes from the meeting, if we're able to get a scope of practice to the March meetings, then that would come back to MDC for review and approval and then goes to the director's office. But we always want to make sure at that point that there's the time for the public comment and for people to weigh in. So we really, it seems like we have 11 months to accomplish this before the end of the calendar year, but that time frame does go pretty quickly. So I think this group really will be vital in terms of making sure we have a great critical care endorsement. The EMR one, there is a national standard for that, so that should be a relatively simple and not as much work, but definitely would like this committee's involvement with the development of the critical care pathway. I want to open up to some questions. I know there's many people that have reached out to me over the years that have said, whenever you do this, I want to participate, and we always make sure that these are open to everyone. But I think this is a great opportunity for us as a state.
So do you have a desire to work this similar to how we did some of the TTTG updates where we have sort of a combined working group between PMD and MDC to sort of cut down on the redundant discussions that kind of go back and forth?
So I think that's definitely a great opportunity. As many of you know, many of you are on PMD along with MDC, and so there is some overlap between the two committees. And certainly when there's a big gap of a few months between, some of those conversations can get difficult. I'm not adverse at all to coming up. We just go through the normal process like we do this committee, where it's sent out well in advance. We publicize it, sent out by Gov Delivery, and follow all the open meeting rules. So if that's the desire of this group to try to combine that, I'm certainly open to doing that. We would probably want to link in, which you're the chair of the education committee, just because we want to make sure that as we start looking at this, there's obviously the overlap of how do you train someone, certify them, and get a scope of practice. So those things all kind of overlay with one another.
In the interest of not people meeting.
But I think it is a good point, because we do sometimes have the issue, as we know, with the TTTGs, which I think we fixed by bringing everyone together for that all-day session of when we have a 2 to 3 month lag time between meetings, people have forgotten what the previous discussion was. And as we're on a deadline for getting this, I think live, Ruth Ann said, by the end of this calendar year, we have to get this in place for critical care. I'm comfortable if that's the desire of the group to move forward with that.
Happy to figure that, especially if we could do it all in one day. But it's not that it's a table, but a half day would be almost.
So it sounds like, at least from those in the room, they're interested in having a combined session to look at doing the scope of practice. How about anyone online? And happy to take feedback too from people who are not members of the committees as well, because we want to make sure this is a huge change for the state of Arizona. So we really want to make sure we have great participation. So we do hit a quorum issue that we do have to meet. So if we have a combined group and just say we're going to set aside 4 hours, we do have to hit a quorum. So that's the one key piece. So we, for MDC, that we need 7 of you guys there to hit a quorum. So That is the one caveat is we do have to hit that magic number to get quorum and be able to actually vote on those items. We would make sure we give people lots of notice, just because we do know everyone's shift schedules are probably made several months in advance. I don't hear anyone opposed to that format, so I will take that as a positive sign. So we will work on that as a combined meeting. So thank you for that suggestion, Amber. I promise to feed you again and to make sure the order is actually enough food this time.
You know, when she says that, she means she's paying for it herself.
Yeah. All right. Any questions or updates in regards to, I know we kind of quickly covered that, but in regards to the EMR and critical care endorsement pathway from anyone? Next, just a really brief update. I know many of you have been involved in these stakeholder work groups regarding alternative destinations for behavioral health patients. We convened 3 subcommittee meetings from EMS Council. The last one was in December. And really, I think for me, when a health plan and lobbyist reached out to the Bureau and says, hey, we really like what you're doing, we want to participate, that's unheard of and was a great thing. But there was a lot of interest in really trying to figure out how to go live with this. So the Reader's Digest version is this is absolutely something agencies can implement now. There's nothing in rule or statute that needed to be changed in order to go live with this program. Again, thank you from Medical Direction Commission for approving the screening tool, their guideline, which is optional, but really can help an agency implement a safe alternative destination pathway. And I think the last step at this point is really for agencies who want to go live with this is to start this process. And if they do identify continued barriers with reimbursement, certainly we can try to bring all the stakeholders back together. So that is a very brief summary of kind of those meetings. So thank you for those of you that participated. Any questions about that? I don't want to be repetitive, so I know many of you have heard this and have been part of those meetings. All right. I think next up, any agenda items to be considered for the next meeting? Any requests or discussion points? It sounds like we will definitely likely have some discussion regarding the scope of practice at that meeting. Hearing none, call to the public.
Justin wants connection.
Okay.
I'm Andy Sparks with NVIDIA.
Okay. So let me get closer to you just so they can hear you online.
No, so I'm Andy Sparks. I'm with Indivior. I'm the account director here in Arizona for OPVI. Obviously, OPVI has nalmefene in it. So I just appreciate you guys talking about it and considering it. I hope that we can have further conversation as time goes on to talk about nalmefene. One of the reasons why OPVI's kind of come to the market, as Justin said, he helped launch naloxone Narcan. What we're seeing and what we're hearing out there in the field from law enforcement in the jails is that it's just taking so much more naloxone for them to bring somebody back and revive them back from respiratory depression. And so obviously in the past, heroin, Oxycontin, we're dealing with a fentanyl crisis. We need to find new tools to fight this. And that's kind of where OPVI came from. One of the biggest things right now with OPVI is that in our clinical trials, we've seen that we simulated an overdose and caused respiratory depression and then added remifentanil, and then we administered OPVI, and we found that as soon as 2.5 minutes, we had reversal at 80% of respiratory depression, and at 5 minutes, 98.9%. So it's working fast, and in the field, it needs to work fast. We want to see that glimmer of life, that breath of air, so that we're not having to re-administer. And then again, the half-life. So we just appreciate your time, and we hope that as time goes on and we have more real-world data to bring to you guys, that we can reconsider nalmefene. And I would hope, if it's okay, if our medical team could send you guys the dossier with more information about our clinical studies. So any questions? I appreciate it. Thank you.
All right. Anyone else from the call to the public? Right, hearing none in the agenda, there's a list of upcoming events. A reminder, our next meeting will be in May. Again, we will look to schedule a special session and get that out to everyone as soon as possible. We'll hopefully try to get a couple dates here lined up and then make sure there's no significant conflicts with any of the big regional or statewide meetings. So that being said, if I can get a motion to adjourn. Thank
So
you. All right. Thank you very much, everyone. The meeting is adjourned.